Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, we are with Dr. Matias Nochetto, who is the Vice President of Divers Alert Network and one of the medical directors there. Matias, welcome to the program.
Good morning. How are you?
I'm good. I'm looking forward to hearing about your walk through this path of life. It's pretty interesting. So tell us a bit about yourself and what's keeping you busy.
All right. So I'm from Argentina, born and raised in Buenos Aires, and I'm 50 years old, and I have the pleasure, the privilege, and ultimately the responsibility of running the medical department here at DAN. So as you know, DAN is an organization that started in 1980 in Durham, in North Carolina, in the U.S., as a non-for-profit with the intention of being something working like a poison control center for divers. And when I say a poison control center, what I mean is, we don't deal with toxins, or not necessarily, but to be a place where people can call when they have symptoms following a dive, and we can listen to what they have to say, try to interpret what may be going on for them, and then give them recommendations for best course of action. And we get calls from lay people. About 70% of them are from lay people, and the rest usually medical professionals evaluating someone with symptoms. And we get about 5,000 calls a year on the emergency line. Of course, not everything is an emergency. I would say that perhaps 3,000-4,000 of those calls are worthy of a call to the emergency line. And what we mean by that is anybody having symptoms following a dive, they can call the hotline. If you have a question about physics and diving physiology, we'd rather have those calls on a different line that we only man 9 to 5 Eastern Time, or via email. But when you have symptoms following a dive, we welcome anybody to call the hotline, and we'll help them 24/7. Now, my history is, again, I was born and raised in Argentina. And I guess when I was about 12 years old, as many in my generation, we grew up, watching TV shows like Jacques Cousteau and documentaries, and I was hooked with this diving thing. So at 12 years old, I wanted to become a diver, and there was none of the current training agencies in Argentina. The only training agency was CIMAS, the French Confederation, and those guys were not into junior open water diving. For those guys, diving was, for the macho, for the big guys, for the big testosterone, muscular guys. So they told me, no kid, you're too young, come back when you're 18. So I put that to sleep, and eventually, it came a time in my life when I had to decide what career to pursue. And my father being a pediatrician, I was always very curious about how he could grab a baby with the palm of his hand and listen to their lungs and come up with a strange name of a drug and tell the mom, give him this for X number of days and bring him back in a week. And I would look at my father and say, what is he talking about? How can we listen to a baby's lungs and come up with something that I can barely pronounce? So I started medicine for the main reason was I'm a curious guy. Before anything, I'm curious. I want to learn, and I wanted to know what was that all about. And so in the first year of med school, you study like there is no tomorrow, and I needed to find something to, disconnect me with medicine, to disconnect me with so many books and so many hours of reading. So that's when I said, okay, let's go back to that idea of diving. So me and my brother, we went to a diving school, and we joined. And again, to me, the idea was to escape a little bit from medicine. And little did I know, on the first day in my diving course, the instructor was going over respiratory physiology, cardiovascular system, and I was like, oh damn! I mean, I can't move away from this. But immediately I was hooked because I could complement what I was learning in diving school with what I was learning in med school, and vice versa. So that took me to a path where, to me, medicine and diving were my two passions. In parallel, what I was in med school, every summer, I was working as a dive instructor in Brazil. So I did that for 7 consecutive summers, and it reached a point in which I had to choose. When I finished med school, I had to choose between, well, say goodbye to diving and become a regular doctor, or say goodbye to medicine and continue diving, and I just couldn't choose. So the best thing that I could find that could combine both passions was to try to merge medicine and diving. And the only place where I could have an academic, a university accreditation for doing or studying hyperbaric medicine at the time was in Mexico City. So I moved to Mexico City, and what was initially going to be a few months of training in a diplomate course ended up being 3 years in Mexico City doing hyperbaric medicine and eventually doing some research in hyperbaric and diving medicine too. Now, this is year 2001. And in my first year, in 2001, one of my goals was to attend to one of Dan's CME courses, continuing medical education courses, which Dan has been doing since 1982 to be more precise. And so I was going to attend this course. It was going to be in Cozumel in October 2001, so right after 9/11. And because of that turmoil in world's history, some of the faculty, they couldn't fly to Mexico. So I had a background, or let's say an adventure in toxicology. My father was also a toxicologist, and we had marine aquariums at home. And because of this, again, curious mind of toxicology, marine aquariums, diving, I was hooked into marine life toxicology or toxinology. So, I don't claim to be an expert. I always say that in the land of the blind, the one-eyed man is king. So I would read everything I could put my hands on. And so when one of these faculty members couldn't fly to Mexico for this course, the guy that I was working with in Mexico, he was in a way somehow part of Dan, he volunteered me to give the talk on marine life injuries. So I was going to be on the side of the participants, and I ended up being faculty for one topic, which was an experience for me because I never lectured in that type of setting. And after my talk, the CEO of Dan at the time was Dr. Peter Bennett. He was the founder of Dan. He came to me and he said, "Hey, so thank you for bailing us out in such a short notice. I've heard your talk. It was great. And I also heard great reviews. It was great." So I told him what I was doing. Already done some volunteer work for Dan, translating training materials and stuff like that. And after a conversation, he said, "Listen, I mean, we want to grow in Latin America. Are you going to be here longer?" I said, "Well, I may go back next year, 2002." And he said, "Well, if you're here and if you're interested, we might call you for events we do in Central America, in South America, in the Caribbean." And I said, "Sure, great." So I guess I received my first paycheck in 2001 from Dan. And when I finished my training in Mexico and I was returning back to Argentina, they said, "Hey, would you like to continue working for us, at least as part-time from Argentina?" I said, "Well, sure, why not?" And I was being, flown around Latin America, Central America, but in the Caribbean. And at some point in 2005, they said, "Hey, Would you consider joining us permanently here in the US? Rats. Okay, that's interesting. So yeah, I took the plunge and eventually accepted. And between immigration and everything and paperwork, I moved to the US in 2007, and I've been here ever since.
That's interesting. You've been interested in diving medicine since the very beginning, like even before med school.
Yeah. I mean, when I was a med student, I would read anything I could put my hands on. And, the diving medicine and hyperbaric medicine world is so small, and you inevitably end up reading the same authors and the same scientists over and over, especially when you go into the very early days in diving and hyperbaric medicine. And a big part of those scientists were from DAN, from Duke University. So to me, ended up, how I ended up working here, it has been a lifetime dream and a privilege. I mean, I couldn't hope for anything better for me.
That's amazing. So you got headhunted, you got cherry picked by Dan from Cozumel, from Mexico City. They saw how good you were, and they're like, you are definitely coming on our team.
Well, if you put it that way, it's kind of, yeah, I guess you can say so.
So what does a day to day look like for you at Dan? So you're a doc and you're working for Dan. You're one of the medical directors. What is your job? So what do you do for an average day or average week?
So, as a doctor, this is a very unique job. So here at Dan, we don't have a walk-in clinic. I don't see patients. Actually, I don't even have a license in the US because we don't practice medicine in the US. We don't, as opposed to a poison control center that is usually confined to, either a country or a state, and in the US, sometimes by county. Um, our, let's say, our area of jurisdiction, if you will, although there's no such a thing, is the entire world. So we can't possibly have licenses in every corner of the world. So the way we work is, we have a call center, just like a poison control center. And we have here in North Carolina, we have 5 medics. And so we take calls. And we have recently, when I say recently, is perhaps we started this transition in 2019. We started dividing, the 24 hours of the day in 3 8-hour shifts. So the we take calls from North Carolina, 9 a.m. until 5 p.m., and then we hand over this hotline to a team in New Zealand, making sure that they continue working during daylight. They do 8 hours, and they hand over to a team in South Africa, and they do another 8 hours in plain daylight, and then they hand over back to us. So essentially, every time you call the hotline, your phone call is going to be picked up by someone who is fully awake, fully functional in an office setting with all the resources we have, and ready to give you the best recommendations we can. So that's the closest we get to practicing medicine is, listen to what someone has to say and ask enough questions until we have a fairly good idea of what might be going on. And then based on that, we give them recommendations. So as opposed to, what happens in a clinical setting when you say you're in an ER and somebody walks through the door and you see that this is a man, that he is, maybe in his 60s, and he is pale and sweaty and he's holding his arm in his chest. And so you haven't spoken a word with this man and you already have lots of information, right? So in our case, our only clinical tool is our ears and what lies in between them, right? Our brain. So how we put this information together. So we need to be expeditive. We can't see someone, and we need to ask basic questions as, for instance, how old are you? Right? I mean, if you're a man and you're 18 years old, well, that rules out some things. And if you're 81, well, that brings up some other possible working diagnoses. And until we don't ask them how old are they, we don't have this information. So we need to ask questions, try to find what might, and again, might, I emphasize this because that's a huge limitation we have. We can only make recommendations based on what you tell us, right? If someone is calling the hotline saying, listen, I've been diving and we know that they had a provocative exposure and they're complaining of joint pain, some numbness and tingling, well, right, that could be decompression sickness. Now, if this joint pain happens to be, the left shoulder of a man in his 60s, and he also has this pain radiating to his arm and the back part of his shoulder, well, I mean, yeah, that could be decompression sickness, but this could also be the heart. So within reason, we always have to assume worst case scenario. If I'm hesitating between decompression sickness and a cardiac event, well, decompression sickness is rarely going to kill you, but your heart will. So I'm going to say, listen, yes, I understand you've been diving and you could be concerned about decompression sickness. However, I would like to rule something out first. And we try to persuade them to listen to us and why we recommend, going to a hospital to have a diagnosis before we send someone to a hyperbaric chamber to receive treatment. Divers usually are freaked out that, decompression sickness is like a boogeyman. And the real boogeyman in diving is not decompression sickness, it's the heart. So our medics, and that's what we have in our team, we have medics, right? I mean, if it'll be that easy that everybody calling the hotline has a diving injury, well, I could train monkeys with procedures and they can follow that. But I can't guarantee that everybody calling the hotline will only have a diving injury. That's why I need medics and I need them with the best medicine they could come with. And I don't hire them medics, we make them. So once I have a good candidate with good medicine, then I teach them diving medicine and we make them what they need to be a DAN hotline agent, a DAN medic. That's a position we have. And again, just like in my career, becoming this unicorn of a healthcare professional, we turn these guys into this unicorn that is the DAN medic. It's a very unique skill set that in a very unique setting that only happens here. I mean, nobody else in the world will interview more symptomatic divers than these guys here. As a hyperbaric medicine doctor, if you have seen or interviewed, 100 divers in your lifetime, you can say you have a pretty good experience. Now, these guys, they may interview, I don't know, 800, 1,000 divers per year. Granted, we don't get to see them, but you get to ask all the necessary questions to steer into what could be the diagnosis. And it's important to emphasize that decompression sickness, or decompression illness, I should say, it's a clinical diagnosis. So it's based on, a history of a provocative exposure, signs and symptoms compatible with, and then eventually, as the treating physician, you say, okay, I'm going to consider this as decompression sickness, and I'm going to treat as if it was decompression sickness. And if it behaved as decompression sickness, and this was decompression sickness, as we get to a definitive diagnosis, it's perhaps one of the last clinical diagnoses. For everything else, you have a study, you have some imaging, you have some blood work. For this, it's just the history, the signs and symptoms, the clinical exam, and eventually how it behaved when you treat it as decompression sickness. So again, a very unique, environment, and that's how our life is. When medics have questions, we're here to support them. We are 3 docs here in North Carolina, myself, Dr. Saliva, and Dr. Jim Shimiak. He is our Chief Medical Officer. And we also support the team in New Zealand and the team in South Africa. We have partnered with DAN Southern Africa. So the team in South Africa, they have their medical support, their medical team being the DAN Southern Africa doctors, which is a great team too. So that's how we work. That's how we operate.
Wasn't it Oliver Wendell Holmes that said that diagnosis is what 90% of the patient's history.
Yep, yep.
It's interesting you said cardiac because when I was working in Seattle in the Puget Sound area as a dive master, and somebody was down at 100 meters, a pro diver. He was in a dragger and rebreather with his fiance. I don't know why, because it's dark and there's nothing down there, but he had a cardiac arrest and he had to surface with cardiac. He obviously died, but he didn't make it to the surface. And then they got him into the hospital. But yeah, that cardiac events for some of us old guys, I'm sure it's probably common, isn't it?
Well, I mean, the diving population, at least in the US, and perhaps that we should, make that distinction. In the US, I think in general, diving population is perhaps a little bit older than in Europe and in Latin America and certainly in Asia. So, you know, cardiovascular disease is a very prevalent threat to all of us. And so the same thing happens while diving. And the issue with diving is diving, when you want to play tennis, you just buy a tennis racket and you walk into a court and you play tennis. And you may not have a style, but you have fun. The same thing happens with kayaking, with trekking. Now with diving, it's different. I mean, you need life support equipment to survive a hostile environment. And if you don't know what you're doing, chances are you're not going to make it back. And this changes your physiology. Every time you're immersed in water, there are some significant cardiovascular changes or challenges. You have some significant blood shifts, and that adds, stress to your physiology. One of the things that happens when we dive is this blood shift. This creates a relative hypovolemia, and of course we try to compensate this with increased diuresis. But it doesn't always work like that. And some people end up in what we describe as immersion pulmonary edema. So, it's not uncommon for someone with let's say, a few years under their belt to manifest lurking coronary artery disease or pulmonary hypertension, and eventually this to end up in something much more serious than what we initially thought diving was going to be, which is, again, people are obsessed with bubble formation and growth and decompression sickness. And yes, that can be fatal, but it's rarely fatal. Most cases of decompression sickness are mild. And mild cases of the bends, they have a good prognosis with treatment and sometimes without recompression. Sometimes when a chamber is not available, you can effectively treat a mild case with just surface level O2, hydration, and monitoring neurological status to make sure that this case remains being mild. And the prognosis is good anyway. And as you can imagine, when we always say, when you have the money to be in a remote location diving, and you pay $5, $7, $10,000 to dive a week on an island that is 40 hours away from civilization, when you have the money to be there, you no longer have the health, right? I mean, on these liveaboards, you don't get someone that is 20 years old paying $5 or $10,000 to go diving for a week. You don't have that expendable income. And when you have it, you probably shouldn't be there. The best places to go diving are not the best places to get sick.
I'm going to throw you a curveball, Doc. So I think it was a WMS conference, Wilderness Medical Conference. They had a talk on in-water 5-meter depth hyperbaric therapy for somebody presenting with hyperbaric problems. I don't remember if it was the bends or what the issue was, but they were talked about putting him back down to 5 meters depth because they weren't going to get to a chamber. Is that touched? Is that absolutely mental?
So what you're describing is what we know as in-water recompression. Okay, And in water recompression is a known practice. It's a known heroic resource. Now, the problem with in water recompression is sometimes, when you have a little bit of knowledge, that could be a dangerous thing. If you Google decompression sickness, you can find signs and symptoms, and then if you don't put them in context, your mind is going to be playing tricks and you're going to think you're bent. Now, if you Google treatment for decompression sickness, eventually you're going to find what we use in a hyperbaric setting, which is a treatment table, right? A treatment protocol, which is essentially pressurizing someone to a certain depth, and in most cases changing what this diver is breathing from air to either 100% O2 or a mixture of different gases that of course include oxygen. And some people, when you go to remote locations, they may try to connect the dots and say, listen, I don't have a chamber, but what if I could use the column of water to give me pressure? And if I have a couple of tanks with oxygen, I can simulate and copy paste what we do in a chamber, do it in water. And that can be a very dangerous thing. Now, in water recompression is, like I was saying before, you can Google in water recompression and you're going to find many in water recompression protocols. And if you find them and you read them carefully, they all start saying something along the lines of, if you don't have the right environmental conditions, the right training, the right equipment, the right support team, the right patient, and the list goes on and on and on. All these protocols end up saying, if you don't have all of these, forget it. Okay? So in water recompression has many more contraindications than indications. So can it be done? Yes. When you have the right patient, the right supervision, the right environmental conditions, the right technique, the right equipment, the right training, etc., etc. If you don't have this, don't even try it, because things can get really bad. If the patient is too critical, then they shouldn't be in the water. And if they're not that critical, then they don't need to be back in the water. So, and quite commonly we get asked this question. So can you help us? If we have a case like this, we're going to be diving into this remote location. If we call you, can you walk us through, and we be holding hands while we do this? And we say no. If you call us to help you through an in-water recompression procedure, that's the reason for why you shouldn't be doing it. People that can do in-water recompression procedures, they don't need us. So, do we support in-water recompression procedures? No. Right? Can it be done? Yes. But we can't endorse this to be done in the field like a standard way of getting out of a situation. No. Chances are, again, if you don't know and you need our help, you shouldn't be doing it. You can't just copy paste the treatment protocol and do it underwater. I mean, the standard treatment for decompression sickness is a treatment table 6, a US Navy treatment table 6. And that involves breathing 100% O2 at a maximum depth of 2.8 atmospheres absolute for a total time of about 5 hours. Now, divers will know that you're not supposed to breathe oxygen at a partial pressure above 1.4. So how can you say that you're breathing 2.8? Well, because when you're sitting in a chamber in a dry environment, you're not burning up energy, you're not immersed, so your physiology is different. So you can tolerate up to 2.8 or 3 atmospheres absolute in a dry environment, sitting in a chair, doing nothing. Now, when you're underwater, you can't tolerate that much oxygen. Anything above 1.4 is considered of high risk. And beyond 1.6, chances of you seizing underwater as a result of oxygen toxicity is way too high. So it's not the same thing. We can't just say, let's get a treatment table 6 and copy paste it and do it underwater. No, that is absolutely mental.
There's another option for altitude injuries. We treat with a gamma bag that gives 2 atmospheres of pressure. Would that also be touched for using in diving emergencies?
Well, so for some remote operations that you're going to be diving, without any timely access uh, to a recompression chamber, that is an option. I mean, you wouldn't use a gamma bag, but there are some other, let's call them hyperbaric chambers, portable hyperbaric chambers. Technically, they're not a chamber; they're a hyperbaric stretcher, and you can use them for that. I mean, these stretchers, these portable flexible chambers, were not meant to treat someone; they were meant to transport someone under pressure. But it can be done. You could technically do a treatment table 6 with one of these chambers. But so again, for remote operations, having access to one of these portable chambers is, in my opinion, a much uh, better option than trying to improvise in water recompression. The risk is you can mitigate that risk, and you don't have the challenge of environmental conditions and immersion, with what immersion implies physiologically, with dehydration and access to a patient. Well, you don't have access to a patient in a monoplace portable chamber either, but at least you can move the patient while he or she is pressurized, right?
Right. Yeah. Which you can't do in a submerged casualty,
Right,
or have 5 hours of oxygen for them.
right.
Interesting.
But again, I mean, I want to make clear that in water compression, yes, it exists and it can be done. It can be effectively done, but it's not for everybody.
Hmm.
We don't see a time in which you're going to have some online training program on how to treat yourself within water recompression.
So So you're a fellow of the Undersea Hyperbaric Medicine. Is this an option for anyone who wants to get more training, more academic knowledge in diving? Do you have to be a doc to do this, or can us paramedics do this, or what do you suggest for the listener who could be at any level of medical professionals? What can they do to learn more about diving medicine and diving physiology?
Well, we offer CME courses. Like I was saying before, Dan has been offering a CME course since 1982. I think we're the longest standing course of its kind. We only stopped for 3 iterations during COVID. We offer 2 courses a year, one in spring, so spring in the northern hemisphere, and one in fall. And this is a week-long course. It's meant for, I would say, primarily for doctors, but I think on every course we have medics, we have nurses, we have respiratory therapists, and on this course we have 2 courses. On one, we call it introductory course. So we don't assume that the participant has any dive medicine knowledge. So we cover the basics. We're not going to be talking about physics. We think that is insulting people's intelligence. You can read about that, and it's not that's those are concepts that you should already have. But we do cover all the basics with the different types of barotraumas and decompression sickness and gas toxicities and all this basic stuff that you need to know in terms of diving medicine. And we do case discussions and marine life injuries and so on. And then we have another course that we started this year, which we call it the advanced topics. So this is for someone that already has been to our course or a similar course, or they have the basic knowledge and they want to expand. So on this course, we offer more advanced topics, more of the research stuff, more on hyperbaric medicine, not necessarily diving medicine. And the course is an opportunity to nerd out during a whole week. So in the mornings, we have lectures or academic sessions, and in the afternoons we go diving. And I should say that these courses, we usually do them in a diving location, be that usually around the Caribbean. That's our destination usually for the spring course, the one we do around May. And in the fall course, say late September, October, we usually go to somewhere in Southeast Asia, in the Pacific, escaping from the hurricane season here in the Caribbean. And it's a week long, and we try to pick locations like, small resorts where you're going to be interacting with people, with faculty, and with people that have your same passion, and you're going to be nerding out about diving physics and physiology and decompression sickness 7 days in a row, 24/7. You can, I mean, if you're a doctor too, and you do a fellowship in hyperbaric medicine, that's it. That is, at least in the US, the way you get into hyperbaric and diving medicine. I think there are 4 or 5 fellowships in the US, and you can find out more about that at uhms.org. That is the Undersea and Hyperbaric Medical Society. And on their website, they have all the information about their fellowships. And many of these fellowship programs, they send their fellows here with us for a week to have some experience, some exposure to what we do here at DAN. When you're in a landlocked fellowship in the US, chances of you seeing a diver are slim. So at least we host them here, and they can see how we operate, and they can interview divers and witness how they evolve from the suspected diagnosis to the treatment, and eventually being discharged after treatment.
So that's where you met Dan, wasn't it? So you went from Mexico City down to Cozumel to one of these CPD course weeks. Is that right?
Yeah, one of the CME courses. Yeah, that was my first interaction with Dan's staff, with at the time the CEO, Dr. Bennett, and it was that opportunity when they volunteered me to give this talk on marine life injuries that, in a way, opened the doors for Dan, and they were pleased with my talk and my background, being a doctor, being a diver, being a dive instructor, being able to speak the languages in the Americas, so English, Spanish, and Portuguese. And then eventually, I guess it organically evolved into here I am.
No, you also have a dive medical technician. Is that more of what the paramedic should be looking for? Or what's the difference between the 10-day DAN DMT course and the CPD course?
Well, the 10-day CME course is not, again, it's not catered to DMTs, but we have DMTs attending, sorry, DMTs or EMTs, right? Paramedics attending. Now, the paramedic course is a different program, and so the diver medic. So this is perhaps more intended to be the medical support in a commercial diving operation, right? So when you're going to be offshore say in an oil rig platform, you may or may not have a doctor on the platform. So what they have is they have remote medical support, and one or several of these divers is also a medic. So when you're a medic and a diver, you take a course that eventually ends up in a certification as DMT, Diver Medical Technician. And then you are the hands and the eyes of a remote doctor, and you can be the tender, the inside attendant in a chamber, taking care of this injured diver, and also manning the chamber from the inside, and monitoring the patient's progress, and doing the neurological examination, and doing any procedures the doctor mandates, like putting an IV, and doing a neuro exam, just to gauge how this diver is progressing. Now, that course, there are some commercially available courses, and you can find more about these on the website, and it's going to be a mouthful. It's the National Board of Diving and Hyperbaric Medical Technology, and the website is nbdhmt.org. That is the body governing, the training and the accreditation of DMTs, at least in the US. And again, you're going to find there more about these programs and where you can take these courses and how to become a DMT. Now, our medics here at DAN, they're not necessarily a DMT because, I mean, they're not going to be working in an oil rig. And a DMT doesn't need to have necessarily all the, the academic training and the intrinsic knowledge about diving physics and physiology and fitness to dive, because that's not what the DMT does in the field. But our folks here, we give them that training because they are at the front line of interviewing someone to determine if they have a case of the bends or what is going on. And also they can answer questions about diving physics, physiology, fitness to dive inquiries, and so on. So our folks here are, again, another more refined unicorn than a DMT.
It looks like there are some options for people who would be interested in getting more information about diving medicine. Dr. Nochetto, my final question for you is this. What advice do you have for a new medic, a new nurse, a new doc who is just starting out on their career in medicine?
In medicine, not necessarily with diving medicine, right?
Yep. Straight like austere medicine, remote medicine is kind of our focus, but you can comment on anything you like.
Oof, I mean, I know you guys at Corom, you have some fantastic programs for anybody. I mean, I can't imagine anybody with a better program or a better overview, a better path for someone in these austere environments. And that's what we're excited also to work with you guys to see what we can complement from what you guys do, what we do. And I mean, the best recommendation we can give someone is a medic and DM and an EMT, a paramedic, is try to be the best you can. Try to become the best element you could possibly be with your training and we have a few medics here that they are bookworms and they are constantly trying to learn more and more and more and more. And follow your passion. I mean, it's always easy to connect the dots backwards. In my case, I ended up on my feet. That doesn't mean that my move wasn't risky. But if you follow your passion, you dedicate, you have commitment, and you make the effort to be the best you can at what you do, your chances of success are, I would say, significantly higher. Of course, I mean, it doesn't always depend on just you. It depends on your environment, there could be politics and anyway, number of things. But follow your passion. I ended up with my passion. I ended up in a different country, different culture. Well, not so different culture, but different country, different language. I moved my family. It's be dedicated. Be dedicated. Be the best you can.
Doc, thanks for the time today on chatting with us. And I learned a bit about diving medicine, and it's impressive what you have done and what Dan is doing for the world of diving medicine.
I'm privileged. I'm lucky that I ended up in this great, absolutely great organization. This doesn't exist anywhere else. I think if we have to invent it, in a part of the world, I don't know if Dan would exist again. It was the result of different conditions, different situations, division of a handful of people, and luck and a huge support from the diving industry. So, I mean, we are privileged to have the support we have, and this is why I love this company. And I always want to emphasize the N in DAN, right? The network. DAN is much more than those of us working under this roof. DAN is everybody that is committed to dive safety, researchers, clinicians, scientists, and committed divers, and people like you guys that keep on supporting us with things like this. So if anything, I'm thankful for the opportunity. And if anybody is interested to know more about Dan and how they can, get their feet wet, literally, pun intended, with this field of medicine, more than welcome to drop us a line, call us, and we'll be happy to steer you in the right direction. And who knows, you may end up working here too.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.